Thank you so much, Nikki, for the kind introduction and for the organizers to inviting me here. And you gave me a quite provocative title, Vaccines Free to All or Sold at a Premium. And it gives me the opportunity to actually immediately debunk one of the myths that we often hear, that certain things could be for free. And actually, one of the points I want to make is that free for all doesn't exist. There is always someone who pays. And usually, actually, it's us, it's the people. Either we pay vaccines or medicines out of pocket individually or collectively via taxes that our government collects, and with that funds public health systems and sometimes also healthcare, sometimes also collectively in plus or minus inclusive ways via health insurance premiums. And often a combination of all those, because as you know, how we finance medicines and vaccines is very complicated often and different in different countries. But so the real question is, how do we as individuals and as a society pay for vaccines? And to whom do we pay? And what do we get for what we pay for? And turning the question a bit further, it becomes, what is the best way for a society to pay for the vaccines that we need and want for public health, so including the medical innovation to get there, and, very importantly, have them available when and where needed, equitably and affordably. And especially that latter aspect is not always taken into account. And so that brings me to why are we having this conversation? And I think you're all familiar with this graph that reflects the situation of access to COVID vaccines on the 1st of March 2022, so 14, 15 months after these vaccines became available, a major breakthrough. We've never had so rapidly new vaccines, but their availability and access was highly inequitable, a situation that Dr. Tedros, the head of the World Health Organization, referred to as vaccine apartheid. Now, why did we end up in this situation? We heard a little bit yesterday about some of the geopolitics and the hoarding that Western countries did. We've just also heard about vaccine hesitancy. But the main issue that was at stake there was that actually the control, the ownership over these vaccines was in the hand of private companies. They were not driven by public health ownership. And as we will see, this is something that has a major impact on how indeed we get access to vaccines. And I want to come back to something like, why do we even have vaccines? What is the system through which we make and deliver vaccines? And so, is it really for public health, or have we kind of derailed into a for-profit system that has forgotten public health? And I want to remind everybody, despite some of the hesitancy that we heard, overall, vaccines and vaccination are amongst the most transformative inventions and interventions in public health that we have witnessed the past 100+ years. Another particular characteristic, because therefore, vaccines and pharmaceuticals in general, but vaccines are not just ordinary commodities, but they're also based on lengthy and costly research and development efforts. There is a lot of technology and knowledge involved. There is a lot of regulation because we want vaccines to be safe, effective, and of quality. There is also a lot of risk of failure in the development of vaccines. So it's not an ordinary commodity. But what we have done as a society, collectively, politically, is we have chosen today that we have a health innovation ecosystem, a business model where we have delegated the supply of pharmaceuticals, including these very important vaccines, largely to the private sector. That, of course, functions within a market logic. And so it means that we believe that private investments and private sector entrepreneurialism is the main driving force to get us the vaccines, which, of course, and I'll come back to that, massive public policy support and funding support throughout the whole R&D value chain. But in essence, the initiative, the ownership, and the control sits with the private sector, and so also their priority setting. And priority setting, therefore, becomes based on market prospects rather than health needs. Because the primary objective, these private companies and many are multinational behemoths. They are pursuing profits, growth in the market, shareholder return, investor return, etc. And a core policy tool to be able to do that are monopoly rights. Patents, trade secrets, market exclusivities on both the technologies, the knowledge, and the final products, which give an enormous pricing power and a control over who gets to have access to the vaccines, who to sell to, where to manufacture, etc. Now, I think it's important to remind ourselves it hasn't always been like that. Major medical breakthroughs in the early days of the early years of the 20th century, and I think, for instance, penicillin, insulin, but also the polio vaccine, were made with the idea of serving public health, and they were made widely available at a very low price and supported such that everybody could benefit. However, during the 1980s, and we certainly in the Western countries, we lived through a political climate where the idea was that the private sector could do things better. There was a lot of privatization also of public infrastructure, including, for instance, many countries had vaccine manufacturing capacity because vaccines were considered as so important for public health. But we've moved that all to the private sector on the idea that it is possible to create a win-win situation between the interests of pharmaceutical companies and the health needs. And so the assumption was that the private sector, given a number of incentives, and I don't have time to go into detail here, but there are a lot of public policy incentives, both financing for public research, for clinical trial infrastructure. We buy the medicines or the vaccines at the end of the day, again with public finance. There are public policies such as the intellectual property policies that are very generous to actually create a situation where private investors think it is worthwhile to actually invest in medical innovation and then be able to produce vaccines or pharmaceuticals. But so this assumption of win-win, that it was possible to do both, actually what we have learned is that the reality is that we have a growing misalignment between what drives pharmaceutical companies, especially with the recent financialization that really focuses a lot on maximizing profits, maximizing shareholder value, maximizing these revenues via sales, a lot of sales, high prices, and also minimizing risk for failure. And what we actually need for public health is actually developing medicines that address public health needs, but it doesn't fit with the prerogatives and the imperatives under which the pharmaceutical companies are today. The same, we need therapeutic advances, not more of the same, as many of the drugs and new therapeutics that come to market actually offer very little therapeutic advances. And last but not least, we want them to be widely available, accessibly, affordably, which all completely contrasts with the imperatives of the current financialized industry. And so what we have today is actually a multiplication of market failures that also, and I think someone said yesterday, Agnes, that basically if there are market failures, it is public investment and policy that is there to correct, but we are not having these corrections. We have public health failures as well, because if you look at, and on the left you can see a graph on looking at all the new medicines that have come to market, you see that more than half of them do not represent any added therapeutic value. So there is a lot of wastage in the system to get a few important medical breakthroughs, but many get to market, and apparently the business model allows that and makes it profitable. At the same time, we have many medicines that are missing. Everybody knows about the threat of antimicrobial resistance, antibiotic resistance, I'm sorry. We don't have a robust pipeline of new antibiotics. And even old medicines are increasingly in stockouts, ruptures, because it's not profitable enough to keep them on the market. And the few breakthroughs that we have, and I don't want to deny that there has been major advances, are often too expensive for health systems to actually be able to afford them, even increasingly in wealthy countries. So this is the market failure in general that we have with this system. Now, if we think about epidemics and pandemics, what we've learned from Ebola, from COVID and other epidemics is that the market particularly doesn't work for outbreak diseases because there are particular characteristics of epidemics. For instance, they are unpredictable. We don't know when, where, what will be the next outbreak. So as a market, I mean, you don't know what it might be. So of course the market doesn't work. Often, and well, COVID was an exception, most outbreaks are small, localized, and represent an insignificant market to be attractive for pharmaceutical companies. Another practical difficulty is that clinical trials are an integral part of the outbreak response, which is a really complicated element. And I was part of Doctors Without Borders when we participated to a clinical trial for Ebola therapeutics in DR Congo. And I can tell you that combining like being in an emergency of Ebola and trying to do a quality clinical trial to establish the efficacy of novel interventions, it is very challenging. And so for pharmaceutical companies, those are all major disincentives. And so all of that to say that the dynamics that we have in the market play against equitable access. And so let's talk a little bit about the vaccine market, because that one too is very curious. So if you see, these are data from WHO Global Market Vaccine or Vaccine Market Reports 2022, I think. So looking at the top 10 manufacturers by value, you can see that 4 major pharmaceutical companies capture 73% of the total market by value. However, they only represent 24% by volume. And in fact, the single biggest producer of vaccines by volume is the Indian Serum Institute, but they only represent 2% of the value. And so you have this total imbalance, segmented market, where we have, over the past couple of years, a lot of efforts to build a market for developing country vaccine manufacturers, DCVM, that through some market push and pull mechanism, primarily driven by donors, by Gavi, by UNICEF, are focusing on economies of scale, getting the lowest cost and price as a cost-plus production, but representing no real added value financially. And so what you have is actually 2 different value propositions in the vaccine market. At one hand, you have a high-income country vaccine market where you have generous government intervention to create and maintain this very profitable business case for private companies. And we all know that the pharmaceutical industry is amongst the most prosperous and profitable industrial sectors, in part because there is also support of long-term investments in research, development, also domestic production with subsidies, grants, assets, generous IP and regulatory incentives, and the willingness to pay premium prices, and public health vaccination programs that are willing to pay for that. So this is a very easy, profitable business model. And if we think about health security, you have instances like the US BARDA. Other countries are now, after COVID, setting up similar mechanisms which actually offer additional, what we call market push and pull mechanisms to incite private companies to work in those areas of health security. On the other side, we have a low and middle income country market that is primarily donor driven, and donors want to have, as they say, I think in the United States, the best bang for their buck. And so it's really driven to economies of scale, large producers, really cutthroat competition. And so with nothing to create actually a viable ecosystem, as we have done in wealthy countries. And so it assumes also that the overall and mainly high-income country market operates fine as is. It delivers health innovation that then and where the equity can be solved by post hoc through charity, through donor-driven markets, etc., ensure that also poor countries can have a part of the market and have really this market segmentation is built into the way we've conceived this market. But what we then do not do is address the structural inequities and dependencies, and it's all came back in our face, obviously, during COVID. And I think Agnes said that yesterday as well. There was not a problem of money during COVID. It was actually access to the technology and the knowledge, and where indeed the intellectual property rights that pharmaceutical companies hold as if it's their private property is indeed their sacred cow, and we're not willing, even in the biggest health crisis of our lifetime, to share it such that other countries could produce and have these technologies. And so this brings us to the work that I've been engaged in, including with members of the independent panel that have been mentioned several times, and some of them are here as well. Actually trying to say, well, if we want health equity, we really need transformational change. We can't keep on tinkering in the market and in the margins and fixing little market failures here and there. We need to really shape a global health industrial ecosystem for the common good, not for building GDP, but actually for driving health. And actually in the WHO market report that I showed earlier, the data of, they come to a similar conclusion. They say we need to strike a much better balance between serving national interests, global public health objectives, and commercial incentives. And this can only be achieved through high-level diplomacy between countries and a commitment to a new paradigm. And this is where we have the opportunity today with the high-level conversations that are ongoing, including at the World Health Organization, World Health Assembly, for a new pandemic accord, where there is a real opportunity to try to come up with something different, because more of the same is not going to get us anywhere. And so we've been working with a number of members of the panel, but also broadening and bringing in also scientists and developers from the Global South, people who really want and are, by the way, already developing and manufacturing, but they feel that they don't have the space and the means to be an equitable partner in this endeavor. And so this is our latest paper that came out just a few weeks ago, where we really try to articulate how such a new value proposition can look like, how to move from the private incentives to a real public health-driven R&D ecosystem, end-to-end, from the science to access, where everything is really included and where you have this equity through every step. And one of the key elements, and I invite you all to read the paper, it's very rich. We did a lot of work on that, and really also with partners from Thailand, from Senegal, from Colombia, from India, to see like, what do people need in the Global South? Because the problem is not in the Global North, right? And I'm sorry to use these terms. I know that they're not ideal, but I think you understand what I'm trying to say. And so one of the proposals is really, can we set up regional R&D hubs led by local regional scientists, developers, that can actually rapidly adapt these existing technology platforms that we are using for vaccines to newly emerging threats. And we call that last mile innovation, because as you will remember, the fact that we had vaccines for COVID in less than a year was because there are a handful of established vaccine platforms, and scientists adapt them to the new pathogen at threat, whether it's inactivated viruses, whether it's adenoviral vectors, even mRNA technology. It's the first time that we had vaccines, but the technology was already there, and what the scientists did is just switch what they were doing for developing or finalizing the development for COVID. So if we establish that capacity to do that last mile switching in the Global South, in a number of R&D hubs, and give the resilience and the trust also that they can develop their own vaccines and manufacture them, which of course means that we need to equip those hubs with the means to drive such innovation to address their priority health needs. And that means access to technology and know-how, including the freedom to operate and not be blocked by intellectual property rights held in the global north or elsewhere. It needs skilled human resources, of course, and access to appropriate capital. Capital financing that supports the public health mission, not capital that needs to maximize financial return on investment. And of course, linking that to independent clinical trial networks that can do the trials that we need to address the public health questions that we need, because that too has not always been the case. And the local manufacturing capacity. Everybody talks today about local manufacturing capacity, but without the link to the ownership or the control over the technologies and the R&D pipeline, we're going to just have the same inequities again and again. And so all of that together must be governed for public health purpose, and therefore it requires a totally new value proposition and economic proposition. And luckily we can count and we can rely on work that has been done notably, or for instance, but also notably by the WHO Council on the Economics of Health for All, chaired by Mariana Mazzucato, where a group of economists and health experts came together for 2 years and said, well, if the goal of our economic or our society is health for all, how can we rethink the economic rules, whether it's financing, intellectual property rights, capacity, trade, anything? How can we redefine the rules of the economic interplay such that the result is health for all? And specifically, there is the final report, and you have the link there on the screen. Final report covers the summary of 2 years of work, but there is also one brief specifically on governing health innovation for the common good, with a lot of very concrete ideas. And to say that it's also not an abstract idea. There is a very interesting project ongoing, and maybe before I go there, some countries are doing that. I mean, Brazil, for instance, has a health industrial ecosystem. And so I think that they are much more advanced in that thinking, that they mobilize their industrial capacity and their science capacity for public health. So it's not as if this is something new, but there is also a very interesting new initiative, which is the mRNA Technology Transfer Hub program initiated by the World Health Organization together with the Medicines Patent Pool, where actually a group of researchers and developers in South Africa are reproducing basically a variant of the Moderna mRNA COVID vaccine to master that technology and be able then to share it with 15 or plus developers, manufacturers, public and private, in 15 middle-income countries, with the idea that they, not for COVID specifically, but will have that technology to actually next time be better able to address any health needs or use it for the health needs that they have today. And there is a report upcoming from the WHO Economics Council also articulating this project in terms of how can we govern that for the common good as an example of these regional R&D hubs that we have been proposing. So in conclusion, to finish, I think it's really important to ask the right questions and to use the right narrative. And so this whole issue is not a question of price or even cost, but about financing for health, not financing of health, but really for, and take that whole of government approach that others have already been mentioned. It's also not a question of public versus private. We need to set up ways in which we can productively govern the collaboration between public and private partners, but with the goal of public health, and unambiguously, not trying to create a win-win because we've failed in the past, and also not socializing the cost and privatizing the gains, as is often the case with public-private partnerships. And then, of course, the key there is, again, can we define the purpose and then design that end-to-end approach, whole of government, and build a value proposition that actually makes it clear how these public and private partners can work together, how they can be financed, governed, including the important issue of ownership and control over the knowledge and over the products, but to achieve the health goals. And one element there that I think becomes more and more critical is to kind of step back and say, look, critical health technologies and the underlying knowledge should be considered global commons, not privately held commodities. And so I want to add a sixth element to the list of global commons that Agnès yesterday laid out. And then we need to think about how are we going to govern that collective knowledge. And I was yesterday in the plane with someone who worked in a totally different field, and he used the term custodianship. And I quite like that term. Like, how do we collectively have the custodianship? Because knowledge, I mean, knowledge is of everybody, right? And do that in the public interest with open science, sharing, collaborating, rather than the proprietary competition in which we are in some kind of a rabbit hole. And with that, I thank you for your attention and happy to have questions.